So good afternoon from India. This is Shekhar Shah, the Director General of the National Council of Applied Economic Research. And we are delighted to be hosting this webinar with the COV-IND-19 Study Group in the US, based largely at the University of Michigan in Ann Arbor, but also with an important anchor at Johns Hopkins University. In the webinar invitation that we sent out bios of our colleagues who are joining us and who've been doing remarkable work in the last few weeks on trying to track the COVID-19 and the coronavirus pandemic as it comes through India. We are in the 21-day lockdown period, as all of us know, in India, and we are soon approaching the end of that period. So this is a very opportune time for us to be thinking, studying and discussing how we have done in this lockout period and what is next for us and for this incredibly large country with incredible diversity and incredible history, but now facing perhaps one of contemporary India's biggest challenges, both on the side of dampening the transmission of the coronavirus, but at the same time, minimizing the damage to livelihoods, to the economy, to jobs, to people who are suffering as a result of the standstill in the economy. To discuss all this, we're just absolutely delighted to have Bhramar Mukherjee, the leader of this group. Her CV is with you on the invitation. I won't take any time and save all that time for the discussion itself. And after Bhramar, there's Debashree Ray from Johns Hopkins University, Rupam Bhattacharyya at Michigan, Lili Wang at Michigan, and Max Salvatore at Michigan. So with that very brief introduction and really the urgent need to tackle these issues, I don't want to waste any more time. So over to you, Bhramar.
Thank you so much, Shekhar, and good afternoon, everyone in India, and good morning, everyone in the United States. As it was mentioned, that this is a research product of a study team, and I would like to I'd really like to thank the study team for all of their contribution. And this is a study team led, majority comes from University of Michigan, Ann Arbor, but there are members from Delhi School of Economics, Johns Hopkins University, and University of Connecticut. So how this all took place, this has been a really enthralling and quite maddening experience for all of us. Over the last maybe 4 weeks, not even 4 weeks, we have really gone on this journey. So as we stand in this moment, I'd like to share a part of this journey. So when the coronavirus crisis broke all over the world, and it emerged as one of the defining painful crises of our time, so many of us were quarantined at home, and we're worrying about parents in India, family in India, and this is the first time we feel helpless that we cannot go back to India if something were to happen. We somehow had to channel our energy and find a purpose in this world. And so that started this whole process, and that has grown quite a bit. And I have to say that this is our first presentation, public presentation, because we have been so busy just coding and putting the software out there that we just put together this presentation also in a mad rush. So I ask you for your forgiveness and your indulgence. But this has certainly been a very inspiring experience of our time. So I just want to take a moment to think about where we stand. And standing at this defining crossroads in history, I really want to think about and dedicate this moment to all of our collective positive thoughts and energy to the first responders and the frontline workers who are fighting on the ground and saving lives as the number of infected cases due to COVID-19 crosses 1.5 million worldwide, 87,000 deaths, and we do not know what is there to come. In this tragic moment of pause, reflection, and disbelief, we appreciate the community around us even more, and thank you for allowing us to be a part of this virtual community this morning. We are delighted to present our research. So the three products that this talk is based on are two Medium articles. And as I said, that I'm going to share a little bit of the journey as we do think about the future. I strongly want to endorse the last final product that you see. The first article came out in March 20, that was pre-lockdown, and then the post-lockdown analysis on April 3rd. And we did not want to wait for a journal article or a peer-reviewed submission because the time was of essence here. We were chasing the virus real time. And I have never done research in my life which is so fast-paced and so real-time research. And in a period of 3 weeks, our outstanding programming team and actually were able to put together an app, which is the last link, COVID-19.org, where all the models that we have created, they are run and updated daily. So please do give it a try and let us know your feedback about what we can do. There are some data issues that have been pointed out, but we can talk about that as we go through the discussion this morning. So the outline of my talk, as I said, that I'm going to set up the stage by talking about where we started this work and when we started this work with pre-lockdown forecasting, and then go and talk about post-lockdown analysis. And then we'll talk about epidemiologic models. And I'd like to remind you the famous quote by famous statistician George Box, that all models are wrong, but some are useful. I'll try to articulate some of those usefulnesses this morning. And then the final thing, that there is not a clear answer to this story. As Shekhar mentioned, that this is a very puzzling problem where economics and public health are pitted against each other, and one benefits and then the other probably it's getting affected in a negative way. How to properly formulate this in a cost-benefit analysis, this is a very daunting challenge. So we're going to talk a little bit about visioning and looking forward as we come out of the lockdown. So when we started this work, we were standing at March 19th. So the first Medium article actually came out on March 20th. This is where we stood, and very, cases in the hundreds, few deaths, but the projections, and I think that in every country, when US saw 15 deaths, and then now it is at this point, this has been a collective failure of our societal imagination, because we are very used to a linear way of life. Exponential growth has been really surprised the community and society quite a bit. So we forecasted, and we are particularly worried about India because there are some, and we'll talk about some of the benefits that we think is going on in the Indian population as well. But all the other risk factors which have been identified with severe risk of disease and illness for COVID-19, there is a large number of people in these risk categories, including hypertension, cardiovascular disease, and population with diabetes. In particular, also the healthcare system with a large number of uninsured patients, about 0.7 hospital beds per 1,000 people, limited number of ventilators and ICU beds. And in the whole world, the healthcare system in most advanced countries have collapsed. And so we are more worried about India in terms of the demographics. But India also has some advantages in terms of a younger population and other risk factors that we are going to discuss in a moment. And so when we projected, so this was our pre-lockdown forecast, and we compared India, and you can see in this bar graph, we compared India with US and Italy, and we projected that by May 15th, there could potentially be from 60,000 cases. And I really like to point to your attention to that dotted line, which is the upper credible interval. Many of these forecasting models are coming up with point projections, but there's a huge uncertainty associated with anything that we say with the limited data we have. We cannot really do everything from nothing, and so we are still in the beginning, early phases of the pandemic. So we projected that about 900, the upper confidence limit, that circle is around 900,000, and the point estimate, the top of the right bar, was right around 60,000. But then the media really got grabbed onto the numbers, so we got a lot of press coverage because of this. And within 2 days, I had to recalculate my estimates for for a group, and then within 2 days from 60,000 it went up to 97,000, and that 900,000 confidence interval went up to 1.3 million. So you can see every day the data is coming in and these projection models are changing, and that is exactly why we had to figure out a way so that our models will run every night and update the forecasting at the app and the website that I shared with you. So then, based on all of these projections, we are standing at a very critical moment. What is going to be the next decision? And on March 24th evening came the historic decision of a 3-week lockdown, and with a 3 hours notice. And the lockdown is a very effective measure from a public health point of view. And it is best if you actually implement it early enough in the disease course. The cost of shutting down a country is probably the same whether you do it in the early part of the pandemic or the later part of the pandemic, but the efficacy from a public health point of view is the better when you do it earlier. So, but for a country like India, or for any country, it has tremendous, massive collateral damage. And we saw the migrant workers walking back to their homelands. We saw social isolation and trying to create a feeling of solidarity. So there are damages which are, some of which are quantifiable, some of which are not quantifiable, and it will take a long time and a long strategy to recover from all the scars that we are experiencing in every domain. But from a public health point of view, arresting the virus was important, and the lockdown as a national lockdown as a strategy is a draconian measure in some sense, but to put 1.34 billion people under a lockdown was certainly a historic decision. And we can discuss and debate about the decision and how it was implemented and the preparation and the management, but that's not the goal of this talk. I'm going to focus on the epidemiologic model, things that I know about. So in terms of the lockdown, as a public health measure, lockdown does not really get rid of the disease or the virus. It really buys us time to ramp up our infrastructure to fight the disease, to ramp up testing, to really track the pulse of the disease surveillance, set up our contact network tracing, prepare our healthcare infrastructure, and then also use data to optimally deploy resources where it's needed the most. So we can think about whether of course, it really shuts down the economy and there is a massive damage to the economy, but experts all over the world have gathered, and some of them do believe, and I side with them, that you have to stop the virus and then pause and revive the economy. And this is only my personal opinion. At this time of the lockdown, it is very important that to keep the essential supply chain going and support the most vulnerable. And that's the implementation and the challenge of a lockdown or a measure like this. And I do think that the public and the government partnership is very much needed to fight this with united resolve. And this crisis really renders a long-term strategy. And as we are seeing in US as well, that it is not going to go away. It's not going to be in May, we are back to normal. The new normal, the adaptation to the new normal requires not discrete set of jumpy moves, but a continuous long-term strategy. So as a lockdown, as a friend of mine, I have really very rightly, aptly articulated that before the lockdown, what does a lockdown do in terms of a virus? So if the coronavirus spread is coming as a tidal wave, we had a picket fence, and the lockdown really gives us time to build the watchtowers, gives us the ammunition to build the big dams and the escape boats, fight it with united resolve. This caught us off guard, but we are not powerless. So I'll really hand it over to Debashree to talk about the next segment, because she led the work in the first Medium article. And as we go through the presentation, you'll see that it was a total teamwork, and the graduate students at Michigan were just absolutely inspiring. They're going to take turns in presenting as well. So I ask for your patience as we transition through the slides. So Debashree.
You need to unmute your mic.
Yes. when we started this work, the question that we had in mind was how many cases can we see if there was no intervention? And then, how many cases can we see if, we take different kinds of public health measures, non-pharmaceutical interventions. But then the lockdown happened. So, there were other questions too, like how many cases do we expect to see after the 21-day lockdown? And what about the fatalities? Is it going to decline? And we also explored what a successful lockdown would look like and how do we come back to normalcy from such a lockdown. So for this, we look at other countries because, we don't have a randomized experiment to compare, what different interventions can achieve, but we have a natural experiment going on in this world. There are so many other countries that are affected, and we can definitely learn from them. So the first one that we, compared to, so it's Hubei from China, and we see that, they imposed a lockdown around January 23, and we see that the number of cases start to gradually decrease, after 14 to 18 days. And that's because, the virus has a median incubation period of about 5 days, 6 days. And then, out of those which, contract the virus and are symptomatic, 97% of those, develop symptoms in 10, 11 days. So we see, the number of, cases decreases after, 14, 18 days. Next, we come to South Korea. They did not take any lockdown measure. However, they took other aggressive strategies. For example, they extensively tested people. So they fined quarantine violators. They had partial closings and, voluntary social distancing and self-quarantine. And we see that, they took all these measures, around mid-February, late February, around those time. And after that, we see the number of cases gradually decrease again in a 2-week period of time. Next, we compare it to Italy. So Italy has been in lockdown since March 9, and, people are saying, why is it that we are not seeing, a decrease in cases yet? There are still so many fatalities, but, right now we are seeing some decrease. But it took a longer time for Italy because it took the measures, well into the epidemic, unlike South Korea or China. And, their national quarantine and complete lockdown started around March 9. And because they were delayed in taking these public health measures, we see a longer period for, Italy to see decrease in cases rather than the 2 or 3 weeks, 2 weeks that we saw for South Korea or Hubei. Next, we compare it to India. India has taken, stringent measures early on. And, our lockdown started around March 25. Now, if the lockdown is effective, by effective, I mean, if the transmission of, the infection from the infected to, non-infected people, if that could be reduced or has been reduced, then we expect to see some reduction in cases in the next week. So what we are really seeing here is a snapshot of what transmission took place about 2 weeks back. So, there is a little lag for the number of cases and even larger lag for the number of deaths.
Debashree, if I could just interrupt, I know that there's an anomaly on this graph, and I'm sure somebody's going to actually catch it. So we could just say it up front that yes, you're very aware of it. It comes from the Johns Hopkins database, and everybody's looking into why April 3rd looks so low. It's not 24 cases; it's more like 500-600. So, the trend catches up. So just we don't get caught up in this later on.
Yes.
Thanks.
Yes.
Thank you for that point, Shekhar, because we debated because there are many, we're going to talk about this, many data sources as well, because our app updates every day with all countries. That's why we use the Johns Hopkins database, but there is obviously an error and we have contacted them several times now. Thank you.
Okay. Great, thanks, Debashree.
Yes. And then, so we used some forecasting models of which, about which, Rupam is going to speak soon. And there are other forecasting models in the context of India that has been used. For example, this ICMR group, they used a simple SEIR model. So S being susceptible, exposed, I being infected, and then R is removed. So most of these, models feature like the compartmental models, where you model the flow of individuals from one compartment to another, governed by a set of differential equations. And so all these 5 models that we have listed here, they use some kind of SIR model or ACIR model, and some of them also use Poisson regression model. And now I'll let Rupam take over, who's going to discuss more about these compartmental models.
So thank you, Debashree, and hopefully everyone can hear me clearly. My job over the next few slides is going to be tell you a little bit about the kind of models that we are working with. So I will begin with a very fundamental discussion and overview about the SIR model. So the basic idea behind any sort of compartmental epidemiological model is that you put each person in one of a few states. So for SIR, you get 3 states that a person can be in. So those are susceptible, infected, and removed. And the removed compartment actually contains both the recovered and the dead. So a small passing point here could be that people could actually possibly relapse even after being recovered, which are not being modeled here. So we're assuming that once a person moves into the removed compartment, they're staying there. So what's the utility of this? We can actually model the transmissions using the count data that we actually get for this compartments, at least for the infected and removed compartments from each of these countries. And specifically for India, we have used that. However, there's a real challenge from a data perspective that lies here, which is that the true proportions, as is marked by those asking marks that you see below each of the compartments, those are really unknown. What we observe in terms of the case counts and the counts of the recovered and dead are possibly underreportings of whatever lies truly beneath them. So that comes as a real challenge, and we have to somehow extend this model to accommodate that. So for the accommodation of that extension, our idea was to introduce a latent Markov process. And this is not really a new thing that we did specifically in our work. This is an idea that has been stemmed in other works, and there are already existing packages and computational codes that apply this process on other data, specifically on China. So I'll very briefly describe what you are looking at here. So the red triangle that you were looking at below is the actual SIR model, which is the latent one, the underlying one that is modulating the entire process. So the theta t's are actually the true proportions of the compartments, and the S, I, and R tags are telling you which compartment you were looking at. So the entire theta t is essentially a vector containing all these 3 things. Out of that, we only see a realization, which is our YTs, which are the observed proportions. So we see the infected observed proportion and the removed observed proportions. And basically the understanding is that the susceptible is 1 minus the sum of these 2. The simple idea here is that if we could model these 2 in unison in a hierarchical way, and then if we could somehow bring in the interventions in between, then possibly we could have a better idea in terms of forecasting the future. So at this point, I'd like to move to the next slide, where we essentially begin with the basic differential equation that modulates an SIR model. So here, as you can see, there are some important terms that I'd like to go over. So each of these terms are essentially describing the propagation of the compartmental proportions. The first term that you see is intuitive in the sense that the beta is actually a parameter which is telling you per one interaction between a susceptible and an infected individual, how much of the susceptible compartment is propagated towards being infected. So that is why that beta parameter is multiplied with all possible proportions of combinations, which is that theta t s, theta t I, that term. And therefore that term in turn has now a positive sign in the next term and gets added to the I compartment, the infected compartment. However, there's also transmission from infected to removed, and that is modulated by the parameter gamma. And similarly here, we're assuming that...
Rupam, may I just request, not everybody knows the R betas and thetas. And so if whoever has control of the cursor, if you just take people through the equations, that would be helpful, just for the wider understanding of what we are talking about. I understand for us, it's
yeah, that's what I was going to do. I just first wanted to set up the equations a little bit so that I have some context where those notations and everything come in. Yeah, but thanks for the point. So similarly, we have another parameter which is telling you that there is a rate by which the transmissions are happening from the infected compartment to the removed compartment. And again, we are assuming that transmission happens in proportion with the size of the transmission compartment. So that is why you see that gamma times theta ti, that term, which in turn gets added to the third equation that we have. So overall, these three together are describing the eSIR model that we have underlying for the true proportions. The important takeaways from those three set of equations is that you essentially have two parameters that are telling you how you are shifting between S to I and I to R, and those will be useful in the later stages. So now, if we come to the next set of equations, the couple of equations that you see, you will actually see that the observed proportions are now being modeled conditional on whatever underlying true proportions you have. So the YTI is the observed proportion of the infected cell. So what proportion of cases are you observing now? And that is modeled as a beta. So again there, just to make it less technical, think of it as a situation where you are essentially trying to keep the mean of the observed proportion at somewhere around whatever the true proportion is, but also trying to model it with a spread around that mean. And that lambda parameter that you see is essentially modeling that spread in some way, essentially tuning the variance and the information that you have in this passage from the latent to the true observed thing. And similarly for the R compartment as well. However, if you look at those two equations together, conditional on the latent compartment, you see that YTI and YTR, the infected and removed compartments, are modeled separately. So how do we actually connect between them? Because they are dependent, as you have possibly understood from our description so far, because I and R have a very simple interconnection in terms of the transmission. So that is one level of dependence. And also we must have another level of dependence, which is the temporal dependence. So if you have something today, how can you use it to predict whatever it will be for tomorrow? So that level comes in the latent part, because in the latent part, we build it as a process where conditional on whatever proportions we were seeing in the previous day, we model the next day's proportions in a certain distributional way. And what you have to take away from there is that the F part, the functional part that you see inside, is essentially somehow telling you that whatever you see from the other day is going to, together with the parameters, tell you about what it will be in the next day. And again, the kappa parameter has some similar role as the lambdas. It is basically modeling the spread, the variance and information that you have at that point. And then one thing that I am not going into a lot of detail of is that this F can be essentially computed using approximations. So one important parameter here, which I think more people understand, is the R, which is just a ratio of this beta and gamma, which is telling you essentially that at that point of time, on an average, how many susceptible persons are being infected by one infected person. So now if we could move to the next slide, we essentially now set this up as a Bayesian model and try to make inference on it using an MCMC sampling. So our priors are essentially quite intuitive. The first prior for the very zero step of the latent proportions is modeled in a way so that it just matches the expected kind of proportions from the observed proportions on first day. And similarly, we can set priors or initial choices for other parameters. Specifically interesting is the prior for R naught, which is the R parameter that I was talking about, but at the beginning of the process. So that essentially tells you that at the beginning when the epidemic was spreading, how many people are being infected by one single infected individual. And this point is really crucial because what we saw that as you change your data from country to country or maybe even province to province, this actually changes a lot. So depending on what data you were looking at, what country you were looking at, you need to tune your choices for the prior or initial guesses for R naught accordingly. For example, when the other group actually did works on China, they actually found out that this number was possibly somewhere between 3.5 or 3.8. But in India, we saw that it was a lot lower. So now, with that in mind, what we could do is we could now model the interventions that we have. So you already saw that there is this transition from susceptible to infection. What the idea here is that you could essentially simmer down that term a little bit by decreasing the possible interactions between the susceptible and infected quantities. So the quantities that you see marked in red is essentially a time-dependent parameter, which is a proportion between 0 and 1, which is bringing down the effective beta and therefore in turn the effective R that you have. So by changing this pi t, you can essentially have different levels of intervention on a spectrum of mild to extreme. So at this point, I will hand it over to Max, who can now tell you about what exact pi t values we are using in our forecasts.
Thanks, Rupam. So in our forecasting models, we looked at 5 different scenarios, 2 without any lockdown period, those being no intervention and social distancing and travel ban, again, without a lockdown period. And then we compared those models to 3 models that included the 21-day lockdown period, with a gradual resumption of activities to different levels, a moderate level, a cautious level, and then those levels seen before any intervention was taken, which we call normal or pre-intervention. So briefly, these are the different R0 values that are the implied R0 values over time in the scenarios that we looked at in the previous page. So they all started with an R0 of 2, dropped to 1.5 as a response to social distancing and travel ban measures, and then dropped even further in response to the lockdown. Then again, as you can see, they increased to different levels depending on the level of activity and assumed transmission probabilities after the lockdown has been lifted. And then we are modeling 2 different situations which basically describe how quickly the population adheres to the interventions and how quickly they are implemented. So on the top, we have a quick scenario, and on the bottom, we have a slower adherence scenario. So quickly, our short-term modeling for the quick adherence scenario shows that there's a marked reduction in the case counts by April 30th for social distancing and travel ban compared to no intervention, and then an even further reduction in predicted cases under lockdown. We provide a dash line representing the upper credible limit for lockdown, which highlights a significant level of uncertainty in the models. And then if we go to the next slide, we see that a similar pattern under the slow adherence schedule with slightly elevated case counts under the intervention scenarios. But again, we want to stress that the pattern remains the same. Looking at a longer term forecast, we see the initial impact of intervention, which reduce cumulative case counts. However, if activities return to pre-intervention levels represented by that teal line, it could possibly negate the impact of lockdown. Thus, we conclude that interventions would be necessary after lockdown has been lifted to guarantee a long-term benefit of the lockdown.
Again, Max, could I request you, I don't know if you have control of the cursor, but as you describe the various curves, it would be great if you could actually use your cursor to point things out. That's great, thank you. So if you can just go back over this, because it's really important that people actually catch the kind of conclusions that you're drawing. So please, thanks a lot.
So in the yellow curve, that is the social distancing and travel ban scenario without any lockdown period. And then the teal curve represents the normal scenario where there is a 21-day lockdown, but we see the activity level return to those seen prior to any intervention. And I think looking earlier on, prior to maybe June 1st, we see that the normal curve is below the social distancing curve. And then after that, we see that they're very similar, which suggests that the lockdown in the long term would be negated. But we see under the moderate and cautious return, which is in the light blue and the darker blue at the bottom, that if there's some sort of suppression post-lockdown in terms of the transmission probabilities, then we see that this lockdown benefit will be extended into the long term. And then the next slide, this is the same graph, but we're just looking at the incidence instead of the cumulative case counts, which again just highlights that early on there is an initial short-term benefit regardless of post-lockdown activity, but that post-lockdown activity levels can negate the impact of the lockdown. And again, we see that the cautious and moderate return scenarios show that some sort of suppression post-lockdown will lead to maybe a long-term benefit. Yes, and then again, those were the quick adherence scenarios. This is a cumulative case forecasting model for the slow adherence. And again, we see similar trends regardless of how quickly the population adheres to the social distancing measures and lockdown measures and how quickly they're implemented, and a similar trend again in the incidence graph.
So thank you, Max. I'd like to really point you to the website, and if we have time, we can do a demo. But we are strongly committed that anybody can actually check our model, change these intervention scenarios, because these are all hypothetical, and all our code, data sources, everything is explicitly listed. The figure codes and the figures can be downloaded from the app as well if you're using it for a report. And if we can help, and then if we can expand and enhance this app, we'd be delighted to have your feedback on that. So I'd like to sort of summarize some of the takeaway messages from what Max presented in terms of fitting the models. First of all, things that people do not want to recognize, but it is actually staring us at our face, is the high uncertainty in the predicted numbers. There's almost no meaning to quoting the exact numbers because there is a wide uncertainty variation. And as we go long term, I think the uncertainty prediction as data, that's why the daily updating of the forecasting and validating and recalibrating every day is incredibly important. And so the data really trumps models. And why do we still do this? If these numbers are so uncertain and they're changing every day, what is the benefit of this exercise? What is the benefit all of this computing time and personnel time and your intellectual input in thinking about scenarios? Because it actually, the takeaway messages from all these zillions of models that we have shared with you is that interventions, the comparative interventions, the relative comparison is still very, very meaningful. And what the takeaway message is that if you actually, we probably can deliberate and discuss whether a 21 lockdown is enough or not, I'm not going to delve into that right now. But if you have a 21-day lockdown, and if that's all you have, then you do need some form of suppression in terms of social distancing and other guidelines in terms of not having large gatherings and sealing the borders. That will probably remain. The world will probably be quite constrained and static until we get out of this. So I think that what to me, this modeling exercise and to our team, it has lent us a lens to rigorously quantify the pulse and movements of an epidemic, but it is actually an incomplete description, highly incomplete description of the costs of intervention and what the society is undergoing right now as a whole in terms of our economic struggles and our social isolation, mental health issues, getting care for other diseases. So I'd really like to take that exercise as an exercise of how interventions are working and what can we take away from that, these simulations. So I want to really conclude, and with all of these numbers, I really want to think forward. So as I said, from numerical forecasting to long-term visioning, what can we do? So first of all, if we look at these graphs, as you can see, I have plotted many countries, and it is essentially gives you a time that it takes you to double the number of cases. So for these highly affected countries, and you can see US here leading the curve, and so within 3 days, the cases doubled at one period of time. But India is, among all of these countries, is a different situation. So many people have asked me, has India started to flatten the curve, and when can we see it? We don't see the flattening of the curve yet. And we, of course, Debashree talked about the lag time, but you can see that this is a different kind of growth rate that we are seeing. So what is the cause of that? It is the curve. As a scientist, if I plot all of this curve, you will notice that it is behaving differently. I'd like to point out that in spite of everything that we are talking about, we can see people, humanity, science, innovation bending the curve. And you can see South Korea, you can see China, you can see the most of the European countries are also bending the curve. So these, regardless of what models say, these interventions actually work. They work at what cost? That we can debate about. So what is the hypothesis? Why is India different? And why could India be different? And it could purely be a function, and I'd like to really delve as a statistician into the issue of testing, the testing strategy and the testing criteria that different countries have adopted. In my opinion, if I was just following my textbook statistics, I'll never plot all of these countries on the same graph, because different people tested and the case counts mean very different things in different countries. Reporting of deaths, whether the cause of death is attributed not just is it COVID-19 related death, or is it multi-organ failures, or it's just marked as pneumonia or a severe respiratory illness. That's something that we need to really think about in terms of data error. There has been a hypothesis about temperature, and the summer is going to help us. I'm going to show you some data with respect to that as well. And there have been some other different vaccinations, BCG vaccination, use of antimalarials, and genetics, herd immunity, all of these things that we have heard. I see a note, it should not be there. It shows you our rush in preparing this presentation. So Debashree has recently co-authored a paper from the Hopkins group on the BCG vaccination that we'll be happy to share. So I'd like to point out this paper by Nate Silver, where this is coming back to the testing issue, that the reported case counts, what do they mean? And this is a wonderful paper and a wonderful exercise, which actually has an Excel spreadsheet where you can see that the countries which seem to be apparently doing quite well in terms of case counts can actually be doing worse in terms of the actual growth of true number of infected cases. So the missing piece of all of this puzzle is that the true number of infected cases, which is some of them are reported and tested, but there are asymptomatic cases, cases which have not been tested, which are a huge part of the missing data that we have. And what we can see that many epidemiologists and biostatisticians have recommended that to estimate the number of cases, this is a very nice set of papers have been coming out of the Imperial College, that to estimate case counts from fatality or mortality data as opposed to the reported number of cases. And so it's sort of the benchmark, a ballpark count is that behind every death, there is probably 800 to 1,000 cases. And this is based on lots and lots of assumption. As you saw, we said that the R0 moves like this, but who knows how the R0 is moving in the future. These are all conjectures, but I think that we really need to pay attention to this. I'd like to show you some testing patterns. So this is a graph where on the x-axis I have plotted the cumulative number of confirmed cases per million, and on the y-axis I've plotted the total number of tests conducted. Obviously, there is an association. Confirmed cases come as a result of tests, but I'd like to see the pattern, the variation between different countries, and like you to point to Iceland. And actually, this article in the Fortune magazine actually really drew my attention to Iceland and what they had done to do testing. I'd like to show you sort of the pattern of the test and the number of tests carried out and the test positive, which I found fascinating as a statistician. These are very simple curves, and I'm going to go step by step so that you can see the patterns across a few countries that have done widespread testing. So this is United States, and you can see the number of tests increasing. And then right now we are doing like hundreds of thousands of tests. Initially there was a limiting capacity and supply of test kits. And you can see this clear pattern, this trend that you're having an increasing trend of positive cases because your testing criteria probably says you are testing symptomatic cases. So your likelihood of finding positive cases is going up with time. This is the same thing for UK, and you can see that the trend is going up. A large fraction of cases are coming out to be positive, and this is as the pandemic is actually unfolding and going into the later stages. Look at South Korea. So the two plots I showed you, US and UK. So again, a lockdown and social distancing is one kind of measure to reduce the contact transmission probabilities, but testing and contact tracing can also be effective. It has to be managed very well. And as was articulated before, that South Korea did a lot of data-driven strategies to do contact tracing and cluster testing. But the pattern is very different in terms of the testing that you see, the graphs that I showed you before. And even after the pandemic is over, I'd really like to point to this part of the graph. How are they testing? So they're testing in a cyclical manner, and they're not testing high numbers every day, but they're certainly following the pulse of the pandemic so that they can actually trace contacts and their case counts. And so as we are thinking about coming out of lockdown, we really need to be mindful. I don't know whether you can see that there is a little blue dots here. They are detecting, and that is very flat. There is not an increase or association that you see in the growing phase of the epidemic. So how can we track this? So this is Iceland. And again, Iceland started a very interesting strategy. As soon as the epidemic broke out in China, from very early onwards, from February onwards, they started testing. People could fill out an online form through a company called Decode Genetics, and they started testing. And so the flat rate, the constant rate of positive cases is reassuring, and the fact that you're testing a lot more than you're finding positive shows that you have some kind of unbiased manner. And I'd like to go back and say that what is the positive rate across these countries? So if you try to estimate something like a prevalence of the test positive cases, this type of data is really misleading. So you can see in Iceland 7%, South Korea 2%, UK 7%, US 15%, and this is completely a byproduct of how you are testing, who you are testing. We can, and in a discussion part, we can go over the testing part. So is summer going to help us? Is summer going to be the hot summer that is coming is going to rescue us from coronavirus? Is there any evidence? So there has been lots and lots of publication. So this is an analysis done by Sharik and Aritra in our team, where we took the whole world. And what we did was to really correlate the incidence, the case counts in each of the countries, and where we had at least one reported case of coronavirus, and then correlated with the temperature. So as you see, so this is January on the top, and it was only Hubei here. And this is, so basically it's a correlation, aggregated, very crude analysis correlation of the two maps. And then in February, there are more cases, and the US is showing some cases, and other countries are showing some cases, Europe is showing cases, and this is the temperature graph. And this is March. And by this time, most of the world has been affected, and you see a lot of red and yellow spots, and you can see US showing up as the new epicenter, and then this is the temperature graph. So if you have some crude measure of aggregate correlation, the correlation is actually negative in sign consistently. So that shows that higher temperature may lead to less incidence, but I do not think this is credible evidence at this point, a convincing evidence that we can really rely on Mother Nature to rescue us from this crisis. So what are some things that other creative things that people have done? So recently we came across this temperature map idea that people are reporting temperature. This is in US, the website is ushealthweather.com, or I can share actually healthweather.us right here. And what they're doing, and this is very interesting in terms of surveillance and tracking, because India is a very data savvy, data rich, lots of professionals and companies are there. So this is a tracking device. And so what you see here is this blue dotted line is sort of what you expect from flu-related illnesses based on historical data. Maybe in the last 10 years, this is the average that you see at this time of the year. So from February to May. And as you see that things were moving as expected. But suddenly there was this epidemic, and so this went up. And now what you see, that we are talking about all the negative things, how other diseases have increased, but with social distancing, with hand hygiene, flu-related illnesses have dropped. And this is sort of shows that this is falling from these interventions work. And usually we are able to cope with this line. This is average expected, what we see. But if we can create great historical databases where we can monitor such changes in terms of admissions for respiratory illnesses, in terms of reporting temperatures, this can be very effective in terms as we come out of the lockdown and think about surveillance and long-term strategies. Similarly, Google have created this community mobility reports. How are you doing with respect to adhering to interventions? I for sure, I know that my father is not doing very well. He's still wanting to go out, and I am doing quite well because my cell phone is in a very static location. So Michigan has done a wonderful job in staying at home. So you can do those in terms of the community predictions as well. So in terms of summary, I'd like to say that this is really a challenging problem. And we are so going through this alternative waves of fear and inspiration and thinking about solidarity, thinking about resilience. But data can really help here. And as a data scientist, I'm just going to give you my perspective that all the techniques that we looked at, that we really need to chase the epidemic as we think about coming out of the lockdown and then nip it in the bud. And this is a really uncharted territory for policymakers because we take time to decide on something and then the virus is defining our timeline, as Fauci said. So the nimble policymaking, pause, push, and drive in a data-adaptive way is very much needed, and that's hard. That's really, really hard. Doing research this real time has been so hard for our team. We have barely ate or slept in the last 21 days. So using data to also estimate the need for different communities and deploy resources. How many beds do you need? How many PPEs do you need? How many ICU beds? Because we have limited resources, but the advantage is that the peaks are really traveling through the country. So there is actually an opportunity to mobilize resources and think in advance. What are the emerging hotspots? This is a really busy time for all of us. But I'd like to really, last night when I was preparing this presentation, I found this paper. It came out yesterday. And I think as much as we can say that this is really devastating at many fronts, this has also been a time for pause and reflection as just human beings. And it has shown us that efficiency is very important in leadership, but it's very important to have empathy and lead with humanitarian values. And so this paper, I strongly recommend everybody on being human in the face of a pandemic. And the last line actually really is resonating to all of us in any kind of position of leadership or just as in our home. In the face of crisis, we must lead with science and with humanity. We can never forget the cost, that the nightmares that people are going through. So in terms of humanity, people always turn to art in time of crisis. So our lab started an evening session sharing art in the time of Corona. So I'd like to really end by quoting on a positive note, Rilke's poem. After all of this science and numbers, poetry and music and art is extremely important for getting us through this time. Let everything happen to you, the beauty and the terror. Just keep going. No feeling is final. So as we are at the peak of the curve, we know that the curve will flatten and humanity will be at its apex because we have reflected on what matters the most to us. Thank you very much for being here virtually this morning, this afternoon. Stay safe, stay home, and we're happy to take any questions. And thank you to NCAER for giving us this platform to present our research.
Thank you, Bhramar. You and your entire team, and I didn't give extensive introductions. There are links on our invitation to your CVs at your universities. But both the senior faculty here, Bhramar, of course, and Debashree Ray, who is an associate, who's at the Johns Hopkins University, as an assistant professor of epidemiology and biostatistics. and the Max and Rupam and the whole range of other team players who've done this. I think you deserve a big hand, and we really thank you for this. I have a whole host of questions that have come through, and I'm going to perhaps just go one by one.
Sure.
We have about 30 minutes more in this program, and so there should be enough time. The first question relates to something that we all know now, the R0, the time it takes. Sorry, Lili, were you going to say something? I just see your camera coming on. Lili, were you going to present something? No, okay, all right. So the question I had, a person's asking, does the R0, which is the time it takes, or the number of people you infect, an infected person then infects, does it vary substantially between countries? And apart from the nature of government interventions, what other natural factors are likely to be driving this variation? And it's a question that's on many minds in India, given population density, given cultural norms, given the urban setting where a lot of people are living together, and the whole notion of social distancing takes on a very different aspect than in some other countries with sparser populations. Bhramar, do you want to take that?
Sure. So as I think Rupam articulated that the R0 measures, and actually we have now Lili, I should really talk about Lili. We could actually do this work in such a nimble manner because Lili Wang, who is on the call, and Peter Song, these are my colleagues at the University of Michigan, they had really developed a wonderful package and wonderful tool to analyze the data from Hubei. So all the tools were already ready. We tweaked it, and these are Bayesian methods, and we ultimately saw that regardless of what prior you put in, the natural support for values around 2 to 2.5 is what we came up with in all our models. Whereas if you are looking at Italy or US, it is definitely above 3. So so this is an interesting question that whether, and we discussed some of the alternative hypotheses that why is India different, why things are not escalating that at that growth rate. And it could be because of some of the hypotheses we mentioned in terms of vaccination, in terms of use of anti-malarials, in terms of some kind of genetics and immunity. The fact is, the honest answer is we do not know yet, but looking at the data, as I sort of tried to conclude in the next part, I do not think that the R0 we ever saw, and it could be that it's a slow growing process. I would be cautiously optimistic, but not be complacent that it cannot go to that value. We do not want it to go to the value. And it could also be that India sealed its borders and the travel bans came very quickly after the cases happened. So the early measures, the early shutdown measures, the early social distancing guidelines probably have helped with this a lot. That will be my own sense, but we'll not know this answer until a lot of research is being done.
Okay, I have another question on how good do you sense the Indian data when you compare it with other countries? It's hard, obviously, to do this kind of comparison, but given that you are all biostatisticians and you deal with large data sets, and you're doing this for other countries as well, and what might be some of the things that we as think tanks, analysts, the media, the providers of data, the health establishment, what are some of the things we should be working on, even if we can't get the results of that immediately, but for the next pandemic?
Yes, that's a great question. So I think I sort of anticipated your question and arrived at this slide because I do think that I have been asking for just trend data on respiratory illness and flu-like symptoms from different hospitals and metros. That's something that if that was easily available, that would be really helpful. As I showed you, there is an observed historical trend and you can detect spikes as well as slumps in order to test adherence to intervention, as well as an outbreak of an epidemic, so that we can track this. It would be really important to chase this. And then the contact tracing and mobile network. So South Korea was very clever in terms of contact tracing using their mobile network data, and to estimate also testing. Who are you going to test? That's so, some countries have adopted this strategy that people who have very high contact or could be the super spreaders, they should be oversampled because they are spreading the disease much faster. So I think that's a very clever strategy. So if we could have these type of data set, and also fever clinics in community settings and rural settings, the community dwelling and the slum dwelling and the cases appearing there is a real hard question. So what China had done was this centralized quarantine where they completely isolated tested positive and contacts and isolate them from the rest of the population so that there is a complete barrier and drop from that S to I arrow. So we have to be creative, and I have heard many creative solutions coming up in India. India's solution is not going to be the same as other parts. But I do think that if we actually are tracking, have a good sense of the health of the country in terms of metrics, and if we see aberrations and departures are nimble to get on that would be really helpful. In terms of the current data we have, the testing is a puzzle, right? So if we go back to the testing data right now, about 15,000 to 16,000 tests are being done, and it looks actually quite. If we go back to this slide, there is not a pattern. So I do believe that, the fraction of positives are small. And so as we roll out new testing strategies in terms of, antibody testing, the serological test, the RT-PCR test, we really have to have data at hand in a nimble manner that can be processed. So this is a time when you cannot wait your data to be merged and 1 year post-analysis. You cannot do post-analysis. You have to run with the thing. So how to set up the infrastructure for that? To have more data on the contact network of the metros in terms of the states, that would be really helpful. And in terms of deploying and resource allocation, to have a good sense of the hospital beds, the ICU capacity, and what can be done in terms of creating temporary hospitals and quarantine facilities, make the treatment and the test free for everyone. And so that there has to be some incentives for getting tested and not be stigmatized that you want to know the results. And this will lead you to get good care for yourself and also help others in turn. Every small step that each of us take, we have never been an epidemic. So as much as I see that, it has really created this havoc, but it also have given us this sense that we are all connected in this whole world. So every small step I take here is going to affect people of the world. This is a strange, massive, daunting thing. And so data also, I think that I would like to see more testing done, and the ICMR guidelines, new guidelines have come out, and so we'll have to watch for the next few days. But having data in a visualized, usable format every day, I think that would be really critical at this time.
I have another question from a viewer about whether the significant spatial disparity or heterogeneity in the spread of the coronavirus in India is something that models like yours can reflect. Can we customize these much more to the Indian setting, or does that lose the rigor of what you're trying to do?
That's a very wonderful question. So I feel that, if we had more data, so there are many models. So many of the ACIR models have used age structures and contact structures for different ages. And that will make the population the predictions more accurate, because, I'm taking a whole India as an unit. But India is really an aggregation of various hotspots and various rural areas. So it's it's a unification of that. If we can build the model at more micro level and get a macro level projection, that will be much, much better. For that, we need geocoded data in terms of incidence of cases. We need the contact patterns in terms of those communities. We need some health indicators for those communities. So I feel that with all of this information, the models will be much better. Having said that, we can make many, many compartments in the model. And there is a recent, actually review comparing various different models. What is interesting is that all models, so at this time, given the data that we have, it's very hard to fit a very complex model. You can fit this complex model where there has been large number of cases. We know about their individual characteristics of the patients in terms of age, in terms of other comorbidities, in terms of their race, in terms of socioeconomic status. So we have a lot of individual level data on large number of people, and people are quickly assembling this data across hospitals. For example, I know in Michigan Medicine, we are pulling the data and looking at it. Once we get that individual level data, then we'll be able to pin down and identify those parameters. So we can posit a conceptual model, but right now we don't probably have the ability to estimate all parameters. But more micro level data we get, the models will get better. This is a very coarse pass. Point well taken.
Next question I have, and I have a very large number of questions. I doubt we'll be able to go through with them. I want to assure people who have been very active putting up their questions that these will all be transferred to the team. And I hope that they will have the time and the energy after this work that they are doing to respond to you, and we will be happy to be sort of the pass-through for doing that. The question here about, given India's well-known constraints on resources and healthcare infrastructure, was the lockdown the best of the known solutions to try and contain the virus? And this is the tough one. What would you now recommend the government do, given that we are fast approaching April 14th, which is the end of the 21 days?
So this is an interesting question. And, it's as I mentioned, that from a public health point of view, I do think the lockdown was necessary. A national lockdown, if implemented early, is the right public health measure. But a lockdown has to be done right. So this whole analogy that you really are buying time in order to build up, really escalate at an unprecedented rate, your healthcare capacity, the number of ICU beds, the number of ventilators, the other, PPE, the healthcare workforce organization of that. And I'm so inspired by all the state governments working so hard, so actively in partnership with the public, in partnership with the government. So I do believe that the lockdown from a public health point of view is the right thing to do if it's, you have to really manage it and implement it correctly so that people do not die of the other collateral damages from not being able to go to the hospitals because the regular care is severely interrupted, not being able to get essentials, the food chain supply, they cannot die of hunger. You have to ensure income for the daily wage earners. And so all of this, it's such a complex scenario. It's very hard to give the answer whether lockdown was the right. And if you think about just these models, there is so much beyond models to human life that we all embrace. So it's hard to give an answer. But I actually do think that in terms of the duration of the lockdown, so we did some calculations. I just have some backup slides in terms of the duration of the lockdown, because everybody has been asking us that whether a 21-day lockdown is enough, whether it and 28-day, 42-day, 56-day. We hope we don't have to go there. But in many countries, so we did some simulations, and obviously you don't see that much difference. So the takeaway message again between 21 and 28. But there is a substantial difference between 40 as you take the next leap. So most countries have done, and by extension, 2 to 3 months. Is that feasible for India? These are hard questions, because what I really think would happen is that the output of these epidemiologic models in terms of cases and fatalities and healthcare capacity will be put in a big economic model where this is a cost and you can actually do a holistic assessment of what is the cost. This is just the cost from coronavirus cases, but there are other costs that we are not counting. But in terms of numerical things, this is what we found, that the 21-28, there's a clear difference in terms of the drop in terms of the incidence curve and the cumulative incidence curve.
Can I go to the next question, Bhramar? Yeah, so a question about both the plethora of models, but also the fact that the data jump around. A viewer mentioning that your data for today, for instance, was 220. That's from Johns Hopkins, I guess. And the Indian data is currently 199. Now, that's a difference of 20 or 21. But, is there a way, why do we have such varying numbers? And of course, then that drives. And does it matter so much if there's that kind of variation in your models?
Yeah, so a couple of things, and I'll let Rupam, Max, and Debashree comment on this as well, because we have all struggled with this issue, which data source to use. The JHU data source we started using because it was because we are doing models across all the countries, and it was hard to find a data source which has data for most of the countries in the world, as well as India at a daily level. And there are, as you saw, there are anomalies. One day it got reported 24, and we tried to really correct it. And then we thought that, are we going to impute that using the other data sources, which is coming from the Microsoft Bing tracker, or which is coming from another data source from India, covidindia.org, that data set. But then we resisted and refrained. We tried to correct that data source because I want our analysis from a publicly available data source to be reproducible. It is incredibly important. This is not the time for proprietary research. This is not the time for closed research. Everything that we produce is out there for everybody to use and be completely transparent. This has been such a commitment for us. And I do think that it's really the India crowdsourced database that was put together, that was actually shared with us by some people in All India Institute of Medical Sciences. I think that's a better credible data source probably for India, and the case counts really track well with the Bing tracker. And right now with the statewide modeling, if you go to our site, actually, let me take this opportunity to go to the site if I can.
And while you're at it, Bhramar, would you like to take us through your app so that people become familiar with its capabilities? Because that's one of the things I'm sure we'd like to leave behind with our viewers, so that they can actually kind of, use their own mental models in some sense.
Yes, absolutely. So I did that. You can see my slide. So this is our app, and and Max can talk more about this. Max and Rupam, do you have any comment on the data sources? Because I know that you guys have looked at so many data sources, but we wanted to find something consistent, which is for all the countries. For our statewide models, which are going to be released very soon, we are just working very hard on it. And we have models for Kerala, Maharashtra, Delhi, and West Bengal. And then what we saw is that, the crowdsourced data actually is much better reflection. I think what is happening with the Johns Hopkins is that ultimately the cumulative case counts are quite okay, but not the daily sometimes. And every 4 days, I don't know, I see this drop. So I'm a little worried about that. That's why we're doing the model checking with the COVID India data. So let me take you through the app, and you can see that, this is our original article. And then this is a complete PDF report, which has much more. It is like a 20-30 page report, which is much more than a Medium article. And then we generated, so this is the graph for just the case count. So far it's just observed data. And one thing is you can actually take off the countries that you don't want to look at, and the axis will rescale, so you can play around with it. I also want to point out to the interactive feature, which gives us so that you can actually hover over the bars and you can see the number of cases recovered, number of deaths. So it took us our programming team, and I'd really like to thank our Michigan programming team in terms of making this interactive, because and so that's the R Studio functions, and you can see all the cases as you hover over in real time, and the numbers as well. So, and then this is just India, and if you want, you can add other countries as a comparison if you wanted to look at that phase of the epidemic. And so, as I was mentioning, that it has been a slower growth, and the axis here is number of days since the cumulative cases passed 100. And so this is a statewide map, and this is a dynamic map. It shows you a temporal snapshot. And so this is the last 7 days, how cases have actually gone up across the different countries, and it shows the case counts. So this uses the Kaggle data source, because we did not have statewide case counts in Johns Hopkins. So, and then this is the part where we have the predictive modeling, where again, exactly the things that Max showed, but he showed you static graphs in a slide, but here you can actually see all the number of cases on every day that we project, and these models get run every day. So you'll see a new projection, and you can see what is the uncertainty, and you can see the upper confidence interval as you hover over each intervention. So if you want to change your intervention, you can download our code and just change your pies. So our code is here on GitHub, and this is the R package that Lili Wang prepared, and that we use as an underlying mechanics of our code. And you can see that we you can create your own interventions, because these are hypothetical scenarios to give you an idea about what you can do with these tools. And so this is the short-term forecast, this is the long-term, and they keep changing every day. As I said, long-term forecast will have to be taken with a pinch of grain of salt, and you can see the huge uncertainty in terms of the cases. And if you let the model grow, it will grow exponentially, and we will get large numbers. We already know that, but people are going to beat the models. That's my hope, that people and the government and the public is going to beat all of these models and prove all models to be wrong. And so that's what we have been seeing, even with large dire predictions that like 60% of the country is going to get affected. What is happening is because we are at fight. We are fighting this thing and not letting models and exponential growth win over us. But I just wanted to, I don't want to get inspired and undermine the contributions of the models, so you can see, and I really like the interactive feature of these models, and please play around with it. Please let us know that if we can do anything. There will be tabs for each of the states coming up soon.
Yeah, just to tell people that these links are in the invitation that you originally responded to sign up for this webinar. So their first report, the second report, and this application, which of course has a number of the links that to their longer paper. So all of this is available. There have been a bunch of questions about where can we get access to it. So if you just go to the link in the invitation, you should be able to get to all of these. Bhramar and team, you had a bunch of questions in your second piece. And one of the questions was, what will success under a lockdown look like? You've kind of dealt with it. Can you tell us a little bit more what we should be expecting? And of course, you can always do the counterfactual, and you did to some extent. Can you elaborate a little bit on that? If the government was thinking about this, which of course they are deeply, and lots of people are working on this very professionally, what should be the metric that they should be looking at? And the lockout has imposed huge costs, but there will be gains. And so how do we measure the gains in this case?
So I think that if you think about the gains, you can, of course, I think the testament that some of these, the curve itself, is a testament that some of the measures are working, and particularly sealing the borders early, suspending the visas, really giving a static snapshot of where the community stands has helped us. So definitely you can see that the explosion has not happened, and touch wood, I am just, rooting for these measures to work in terms of the flattening the curve and keeping the growth controlled. But we have to be very cautious in terms of setting up the testing. So I think in terms of policy, this lockdown period buys us time. So what we are able to accomplish in terms of building our capacity to fight this epidemic, that's also a positive benefit, right? How many additional ventilators could we acquire? How many, temporary quarantine facilities, hospitals? There is a discussion about making trains to be temporary hospitals. What did we do so that when we see the patients, we can give them adequate care? What did we do to protect our frontline health workers? What did we do in terms of acquiring data and really putting everything on high alert so that if there is another emerging outbreak, we can chase the hotspots throughout the country. And so, there have been remarkable progress. So if you look at Kerala, if you look at all the work that each of the governments are doing, it's the people of India doing in terms of supporting their daily wage earners. So I think it's a united resolve that has brought the country together. That's also something positive. But I do think that I am not an expert in economics, so these two things have to be put together in a model to really quantify whether the collateral damage was worth from the fatalities and the massacre that COVID-19 can cause. But given looking at the whole world, nobody is really saying that you can let the virus go. And then if they did that, they're retracking and course of the path. That tells us that there is some method in this madness. And I really think that the case counts and the flattening the curve and creating and having a better prepared infrastructure and public awareness and solidarity and resilience that this is serious, something serious, is going to be a positive benefit of all of this. But really ramping up the infrastructure, and I really admire, and my hats off to all the people who are working round the clock to enable all of these efficient things. So this is our service. We cannot be on the front line as data scientists, but we can see from our own lives what a toll it is taking working round the clock to do this. Shekhar, you are muted.
Here I am. A lot of questions about comparing the US and India, and both in terms of the ability to social distance, which may be different in the countries, the policy response, and does one country hold lessons for the other and vice versa?
So this is a hard question. I was hoping that you are not going to ask me. So
it's not me, it's your viewers.
So maybe do other members of the team have anything to say about this as I gather my thoughts together?
Debashree or Max or Rupam?
So I think I can at least chime in with one point here, which is that if you look at India, first of all, it's a large geographical region that we are talking about, with different population sizes and different sorts of population densities all around. So even if from a modeling perspective, we are talking about the country as a whole, things are actually happening at a much more granular level. Things are happening at state level, district level, or even maybe a town or village level. And that is very crucial. When we talk about these numbers, like an R0 for the entire country or things like that, how much do they mean in the reality is a question. Even if you talk about the lockdown or the distancing or the quarantines, all these things are essentially separated in terms of cohorts of people. And that those cohorts can be in terms of the geographical locations of them, the socioeconomic status, the groups that we have among the people. So it is really a question of having a sort of synchronous effect of the lockdown on all sorts of people around all across the country. If you have a very good effect of the lockdown, if you have a very good implementation on one part or for one set of people and don't have the same for other, eventually you are essentially disrupting the whole system. For a country like India, I guess that's a big challenge.
So I think that in terms of just a mathematical model of modeling point of view, Shekhar, I find modeling US much harder because there is not an uniform policy yet. There is no national lockdown, so each state and each city has been quite different. So I do think that, so for example, Michigan has been one of the really hardly hit states. And we have been really under severe stress, and it is hitting home. Many of our friends who are frontline health workers are in the hospital, and it's just very real right now. And it's also really in everywhere. If you look around the world, what is really depressing is that even in Michigan and around the country, the disparities in terms of health are emerging, even in the face of the pandemic, that not everybody is equally privileged, and the share of mortality, the share of grief, the share of tragedy hits the underprivileged in every part of the world much more. So there is some commonalities to be drawn from that. But I do think that in US, they really delayed the social distancing and the guidelines, and still there is no national lockdown, which is very different. India declared the lockdown when they had 536 cases and 11 deaths. And this is really hard, because if you actually do these things, and at that time, it may seem you are overreacting. And if it gets controlled, then people will say, oh, you were overreacted because there was no problem at all. So this is a very strange counterfactual. But if you take the other countries as natural experiments, what would have happened, then we'll probably see that there is some point, something to argue about that. And of course, the devastating costs on other fronts, I'm not able to incorporate that in my model.
There's a question here about cluster sampling. Cluster pooling, where you economize on test kits, whether they are RT-PCR or the antibody ones, by actually combining the samples of the various models. But the question is, if you combine 64 people's swabs in effect and then test them, then you are able to more effectively cover a much larger population and do cluster isolation more efficiently, especially in a low test kit availability setting. Would you like to comment on that?
So yes, so I think I have been thinking about this a lot. So this is a sort of a modified framework of what really is going on here. First, so I do think this pooling biosamples, it could be a clever cost-saving idea. And I think Israel was the first country which proposed this, and it's basically pulling the samples together. And so there are several tests now, and in the antibody test, whether we can release people to go back to work because they have acquired immunity or not, that's a big debate going on. And then, of course, there are RT-PCR tests and serological tests, which are more effective when you are a few days into the infection period. But what is going on, if you think about, we need to think about surveillance and testing at sort of all of these boxes. So we have the susceptible individuals who are still at risk. We have the people who are latent, truly affected, the asymptomatic cases, which is the troubling part of this equation. And then we see the affected cases. This is the whole part of the model that you only see the reported ones, the infected ones. And then there is an unreported, so this is the unascertained cases, but these tests have accuracy. So we need to build that into the model. So this is test positive. The ascertained ones are truly test positive, they're true ones, the true positives, and then there are some false positives. This percentage is very low. I think it's 0.1 to 2%. But there is a lot of false negative, and some tests have said that 20 to 30% false negative. So these are individuals who are going back saying that these are disease-free individuals, but they are false negatives. So we need to think about that in the model as well, and then really think about, in the infected people, how many could be managed at home, because the real cost is what proportion of people are going hospitalized and getting ICU beds, and then some are moving to the other two compartments in terms of recovery and death, the arrows in this So we really need to think about testing in each piece to track every piece. So I think that pooling is a good idea in terms of cost saving, but if the tests are quite cheap, particularly the antibody test, if that becomes very cheap, then individual testing is also important. By cluster testing, I did not mean pool testing. What cluster testing, I mean like tracing, for example, if an exposed person or a symptomatic person goes to a church, really test everybody in that cluster or that neighborhood. So that's what South Korea was very effective in doing.
Okay. I wanted to question here about the length of the lockdown. This is something that people are really concerned about. Of course, it affects every one of us at every level almost. And maybe you could go back to that graph. I guess this is the graph, and then talk about the quick adherence, the slow adherence, and if the 2-3 cases that you had. Could you take us through this a little more in detail, please?
Sure. So what we did, again, all of this is like, mathematical ad hocery to some extent, but mathematicians, we do natural experiments on our computers. So it's basically creating hypothetical scenarios of what is going to happen if we extend the lockdown by 28 days and then 42 days and 56 days. If you look at our Medium article, we actually refrained from making a recommendation because we felt like we did not have enough data. And again, it is not really appropriate to talk about just from an epi point of view because there are so many other considerations driving a country managing a lockdown. So, but you have seen that many countries went into lockdown and gradually extended this. So we wanted to still do this artificial experiment where we basically take the 2 scenarios that you saw in terms of people quickly adhering to lockdown so that population becomes static and there is a immediate drop to the transmission probabilities, and then the slow adherence, which is gradual adaptation to lockdown, and that of course delays the process a little bit. So we took that and we extended the period of lockdown from 21, 28, 42, and 56. And what we saw, essentially the takeaway message is that 21 and 28 are numerically similar, and there is a clearer advantage in terms of dropping the incidence if you go to and flattening the curve if you have 42 and 56. But there's another question, right? Of course, you can control the number of cases if you go to longer and longer lockdown and social distancing measure. The equation is the healthcare capacity. So do we have the healthcare capacity to handle the projected number of cases that we are seeing with 21-day lockdown? And the thing is that I do not know that the data that we are seeing is only probably the tip of the iceberg, and there is a lot of other things that we do not know at this point. So given the uncertainty, this is all I can say, Shekhar. I don't think it would be appropriate for me to comment more. This is all in terms of the current data, only epidemiologic model, believing that the case counts are the real counts. So I'd just like to comment on, stop from commenting more on that.
Rupam had mentioned, and this is a question about reinfections. How solid is the evidence about immunity acquisition? I realize that many countries are now thinking of using plasma from recovered patients, especially for frontline health workers. And I suspect that will happen in India as well, if it's not already happening. Any thinking in the modeling world amongst all of you epidemiologists about reinfections?
Yeah, so that's the thing that we don't have. So my conceptual framework where you have the R, there should be really an arrow when you from recovered, you go back to susceptible again. And we have not done that compartmental model. And also I really want to see some data and individual level data as the countries are releasing the individual level data. I think we have to be strategic in terms of really understanding what is the genetic, environmental, socioeconomic profile of the people also who are experiencing a relapse. So we have to really characterize and build models for those people to understand. the idea of plasma banking and helping others, and many COVID patients are, of course, really wanting to donate, and there has been many celebrities who have been affected by COVID. They have been campaigning for that, the plasma bank, to help frontline health workers. I think that until we'll try everything. We'll try every possible way to beat this virus till we have a vaccine or a FDA-approved drug. That's the reality. And there are ethics associated with it. For example, the antibody test, if you see immunity, if you let somebody go back to work, is that safe? And then someone else who has the test negative, then they stay at home. So all of these, it's really a complex problem. But I do think that there are positive directions emerging. And I do believe and have a strong faith, knowing the history of science, I do have a lot of faith in medicine and science and innovation and human strength.
Bhramar, we'll take a last question. We've sort of gone beyond our hour and a half, but the last question is about India's states, which of course are bigger than most countries. And I heard you mention that you'll be releasing state level projections in the near future. How much can the states of India, and there's a couple of questions on this, how much can the states of India learn from each other? And just as, for example, California seems to have done so much better than New York in the US where you are. Can we look to the kind of demonstration effect, leadership? The problem, of course, is time. There's not enough time to kind of, sit back and look at some state and then try to implement it in your own state. What should the states be doing? What should we as analysts be doing to try to get this knowledge and experience across to each other much faster? And what's your experience been in the US?
Yeah, you mentioned a very good point, Shekhar, because this is the world's largest natural set of experiments are going on. So as much as we do not have policy trials or RCTs, we do see the contrast between, even in Italy, the contrast between Lombardy and Veneto. We see the contrast between California and New York, which were at the same point at some point of time. So these are testaments that these measures actually work. So that, as I said, regardless of what the models say, data and humanity trumps models, what we do. And so what I really think that the different contrast of the states can actually really teach us a lot. And that's what we have seen in the US as well. Certain things that are very specific to certain states and being really agile and vigilant. And I know that there are lots of movements going on in different states, but I think we can all get inspired by the initial success of Kerala. But I do think that these are like in the same country. If you look at, sealing the borders, making it static, making people really take this seriously, really scale up healthcare capacity so that you don't have fatalities and hospital admissions. Another thing is very important at this point is the communication. At the grassroots level communication, how can you individualize communication so that you can reach the mass? People are getting source of information from so many unreliable sources, Twitter and Facebook, and also just in the grassroots levels. What is the communication? What is the government communication? What is the science saying in a more understandable format, getting this out there? So it has a large role to play that we have seen in various places in the world now. So I think that there is nothing to be, this is the time where you have to completely let go of your ego. You have to lead with efficiency, empathy, and be able to nimbly scale up the interventions that are working and scale down and shut down the things that you thought were great ideas but are not working in science, in policy, in society.
I have one last question, which is sort of insistently being asked. The question about the fact that the common flu is very common in India. And the ability to distinguish between the common flu and COVID-19 is a major factor, especially in a country where the flu shot or vaccines against flu are just not common. as they are in countries like the US. How does this complicate the detection and treatment of COVID-19?
Yeah, this is exactly right. I really like to point to data. I would really like to point to this graph that we see. We may not have tests for flu, but we probably could get more data on flu-like symptoms. And we can look at hospital admissions. We can look at like healthcare. I really want to get some handle on this data, which are stable markers of what typically goes on. As a statistician, we are always doing comparison between the observed and the expected. And every time the observed actually is departing from the expected, which is the blue line, then we have our guards up. Something is going on. Statistically significant, medically significant, clinically significant. So our antennas are up. So how to get our antennas up really needs this data, that what generally goes on in India in terms of influenza flu A, flu B, in terms of general flu-related symptoms, so that if we see by some mechanism, and we are talking about like, the fever map, that getting temperatures, what is happening, when we see a departure in terms of excess respiratory illness, excess fever symptoms, then now that COVID has happened, we really need to be very aggressive in terms of testing and going out and checking those people. And with fevers and other flu-like symptoms, probably will actually really embody and adopt self-isolation and quarantine measures until we know and until we have tests available. And I think soon the tests are going to get cheaper, faster, reliable results. But I think it's important to track. It's really important to track general illnesses and how to distinguish a bump from the normal.
Okay, with that, let's bring this very fascinating webinar to a close on a subject that really is just so close to all of us and to all of you sitting in Ann Arbor and in Baltimore. I want to thank Bhramar Mukherjee for leading this work and for using her exile from India to good effect. Thank you for doing that. I want to thank Debashree Ray at Johns Hopkins, and I want to thank Lili Wang, Maxwell Salvatore, Rupam Bhattacharyya, and all the other people who I think have contributed to this, both at Michigan, Connecticut, and other places. I think this is hopefully the first of several conversations that NCR would like to host. The more we learn, the more we question, the more we contend with these data issues, with these model issues, the better the policy making that we will have. And that really does mean a matter of life and death. And so I think it's great that we managed to convince you to take the time to do this. Thank you. And I'd like to thank all the viewers who joined us. We were well close to 170 at one point, I noticed. And thank you for all the people who've sent in questions. This webinar is being recorded and it will be placed on YouTube so that people can come back to it. We will have a location where we will put up the link for that, and it'll also possibly be available on our website at ncr.org. With that, again, thank you everyone on this webinar for joining, and thanks in particular to Bhramar and her team.
I'd really like to thank you, Shekhar, and for everybody who joined and sacrificed their Friday evening to listen to this. And I just want to say that if you have any thoughts, any questions that we are not able to answer, please do send it to us. Please look at our app. Data is imperfect. Life is highly imperfect right now, but we can always put our best fight forward. Thank you very much.
Okay, I close this. Thank you. Bye-bye, everybody.
Bye.